and just see whether people, you know, so I can kind of think about, right, next session, what would people like to talk about, and get for me to find cases. Okay, so this one, what do we think here? So if anyone knows, please throw it in, and we can try and work through the problem. Okay, so we're having a look at this chest X-ray. We can see that it's an adult patient. Okay, hang on. Sure, yeah, we've got yeah. So we've got an adult patient over here. We can see that there is, you may be able to see that, yeah, so someone has said that, so they've come in with chest pain. They've come with chest pain. Right, so what we can see here is that there is this area of radial opacity that is located within this region over here. Fair enough, you may think that this patient has got consolidation, right? But consolidation, you need to see where there's air bronchograms, and yeah, fair enough, you don't always see air bronchograms, which can be a reason for consolidation. But you've got to think a little bit more about what else could be going on. You could be like, okay, this could be consolidation, chest X-ray follow-up in 4 to 6 weeks and see if it's resolved. Now, let's say this doesn't resolve and it stayed the same and the patient's still coming with chest pain. One of the key findings of this one is to have a look at the ribs, like see, rib, 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 and then you've got this area over here. Can you see that? And then you've got the rib, rib there, got rib, 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 rib. Okay, so the ribs don't look quite right. The posterior aspect is completely, you know, you just can't even see any sort of outline. And you may think to yourself, well, you know, that's because the consolidation is covering it, but it actually isn't. You know, even if you've got consolidation, you should still be able to see a bit of normal cortical edges here, but there is no cortical edge here. What it turned out to be was actually a destructive chest wall lesion causing destruction of the posterior rib. So just be careful, you know, like I know when you see any sort of shadowing, opacification is very tempting, even in chest pain, to say like, oh, well, you know what, it's consolidation. But just have a close look, have a really close look, and make sure that there is no evidence of any destructive processes. There's no high-low lymphadenopathy or anything else that may suggest that this patient's got a little bit more going on than what meets the eye. So someone's saying, is it a breast lesion? Yeah, I mean, you could say, you may think that because there's a bit of asymmetry to the breasts, but actually this was 100% a posterior chest wall lesion that was causing destruction. So a very plurally based lesion that was causing destruction there. So anyway, I think that brings us to my final case. So I hope that was useful. I'm trying to make it as though as if we're working together. So this is how we'd go with the registrars. Registrars would actually report the cases, then we'd go through the cases together. So we don't have that, but we do have the ability to be able to go through hopefully quite a wide gamut of cases. And by doing that, we get to have a whole breadth of stuff to go over the next few months. And this is kind of, we've done an easy few cases just to kind of ease you guys selves in. Hopefully you guys will come up to the next few talks that we do together and be able to hopefully get through some more interesting cases. And hopefully, and the other thing I'd like to say is that some of the core concepts I've introduced here will help you be able to find the more subtle findings going forwards. Okay, so hopefully that was useful. I'll pass it back to Seidel.